Good evening. This is Josh Goodwin, the doctor at Regenexx Las Vegas. I'll be the one giving the presentation, this webinar about Regenexx Las Vegas and regenerative interventional orthopedics to talk about options for orthopedic conditions. As I said, my name's Josh. I'm the doctor here at Regenexx Las Vegas. We're just gonna go through one of our basic webinars, just trying to educate people on who we are, what Regenexx is, and really just talk about options for orthopedic care. So hopefully you're here to learn more about orthopedic treatment options, since that's what we focus on. Just kind of a little overview of how the webinar is going to go. There'll just be a little background information on myself, on Regenexx, where it came from, how it started, our approach to treating patients and determining who's a potential candidate for what we do. And then there'll be a Q&A time at the end. As you saw, you can write in the chat or the question and answer section, and that will kind of pop up on my screen. I probably won't stop throughout the webinar to address the questions, but we will have time at the end for me to kind of go through them. So feel free to jot them down as they come to mind, and then I'll make sure we spend some time at the end answering questions. As I mentioned, this specific webinar is just more of a general overview of kind of what we do, a little thought behind it, and then it doesn't get into all of the details of all the specific joints or conditions that we treat. In regards to all the specific outcomes, what can be treated, what can't be treated. We do have other webinars that focus specifically on kind of location specific issues. Obviously, you can ask questions about any kind of region of the body, but we have a webinar for low back that goes into more detail about maybe different treatment options and just more specifics. Knee outcomes, we'll make some for other parts of the body, but feel free to ask questions. So I'm a medical doctor. I did my medical school training at the University of New Mexico School of Medicine. I'm from New Mexico. I grew up in Albuquerque. I did move to Texas for my residency training in physical medicine and rehabilitation, which is a non-surgical field that more or less focuses on improving function and trying to reduce pain, which is obviously what we try to do here as well. I did do fellowship training in sports medicine, interventional spine medicine. I am board certified. I've been performing regenerative medicine therapy since 2014, which is what we're going to focus on. And I've been with Regenexx since 2015. And I'm a co-author on a review study for using stem cells for low back pain. Obviously, we're here to talk about kind of muscle, joint, tendon disorders, which we classify as orthopedic problems. And these affect people of all ages. As we can see here on the screen, even young patients, a lot of patients do suffer orthopedic problems, whether it be from, injuries. Some younger patients can have degenerative changes as well. Overuse problems, those kind of things. As we age, it becomes more prevalent. And so we all know somebody that has dealt with an orthopedic problem, whether it be back pain, knee pain, shoulder pain, elbow pain, foot pain, whatever it is. And it costs a lot of money for us to treat these different conditions, both direct and indirect cost. And again, a lot of people have these, which is why we're here to learn about different treatment options. Many of us know about kind of the traditional approach to treating arthritis, wear and tear, overuse injuries, tears, these kind of things. And really the theme of everything is just the more options we have for treating orthopedic conditions, the better, right? Because while some things help some people, they don't help everybody. That includes surgery, right? Surgery doesn't help everybody. So, and it's more invasive and comes with more risk, which we'll talk about. So Most of us are familiar with over-the-counter and prescription medications that can be used, anti-inflammatories, pain medications, muscle relaxants. All these things can be used. They have their own host of successes and failures and risks and complications. There's injection-based therapies that's traditionally given, which is the corticosteroids, the cortisone-based medications, which also carry their own risks, which is why you can only get so many a year. There's more and more data coming out showing that cortisone type injections and even oral forms can be quite toxic to local tissue, including your cartilage and your tendons. So if you want to help protect those tissues, it's best to avoid cortisone injections. Obviously, there's physical therapy, there's bracing and surgery, which can be done, but tends to be more invasive. Obviously, we can see a big incision with staples, metal hardware to replace tissue. Sometimes that's needed, but if we can help avoid or prevent that, that is the goal. So even simple things like taking a Motrin carries risk. There's an increased risk of heart attacks, strokes, stomach ulcers, kidney dysfunction, and kidney failure. The use of these medications is associated with deaths. People die from taking these medications. And so when we can avoid taking them, that's the best option. Sometimes they can be helpful for getting through a flare, but not necessarily the best to use them on a chronic daily basis because they can start to create problems. And if we look at surgery, the more invasive something is, obviously, the more risk it carries. And so if we kind of compare, say for the knee, for example, obviously this can be done for all joints, but the more invasive the surgery, let me move this here, the higher the complication rate is, right? So if you look at knee replacements, serious complication rates can be as high as 16%. And knee arthroscopy, which is less invasive, still carries about a 5% risk of serious complications. And then if you look at outcomes of these things, they don't cure the problem for everybody, right? For knee replacements, only 40% of people return to full activity, and pain is still the most common complaint after, say, a big surgery like a knee replacement. So it's always not what people may expect, or people may get the sense that you replace the joint and you're good, you can do what you want to do, but a lot of people still have pain or dysfunction after that. So what can be an alternative if we catch things early enough to maybe help delay or prevent that? So if we compared the surgical complication rates versus, say, the injection-based procedures that we provide, this is a study that our group did looking at over 2,000 patients and looking at complication rates, a 0.71 complication rate. These are all relatively minor with increased pain, swelling, maybe a little bruising, maybe a little nerve irritation, depending on what was being injected, versus significantly higher complication rates from surgical intervention. So again, it's about options, options, options. You got to know what all of your options are, from medications to non-invasive all the way to surgery and everything in between, to know what's the best fit for your specific problem. And that's kind of what we like to provide, is lay out all the options and discuss what the success rates are and the risks and benefits. So Regenexx has been around since 2005. So it's been here a while. Started in Colorado. Now there's more than 60 clinics around the world. We've treated more than 150,000 patients. We're tracking more than 40,000 patients in our registry. And we're very focused and specifically focused on trying to treat orthopedic conditions using injection-based treatments and utilizing cells and healing and growth factors that we can isolate from your own body, and just taking advantage of kind of the natural healing mechanisms, which we'll talk more about. So just an example of the different Regenexx providers across the globe. This all can be found on regenexx.com. We are the only clinic here in Nevada, at least in Las Vegas area. I don't think there's one anywhere else in Nevada, but they're always adding more clinics around. So, and ever since the beginning, we always follow this process for assessing what we do, always performing clinical research, tracking patients in a registry, and then using this to guide our own treatment options and plans, as well as publish so that other people can be aware of some of the success or failures that we have found in our own research. And so this is kind of our process. This is what attracted me to Regenexx initially back in 2015. Because of this process, most providers in this field aren't really keeping up and tracking data and tracking outcomes to know if what they're doing is working. And so this is really helpful. And really, this is about evolving medicine. As we learn more about our bodies, technology, medicine has to evolve with that technology and that newfound knowledge. And so we're just trying to use some of the knowledge that we do have, and just evolve medicine. And we're trying to take more invasive procedures to less invasive procedures using needles, healing factors that we can derive from your bodies or other sources to help improve areas of injury or degeneration. And as we had shown in the last couple slides, there's less risk, less potential for complications. Doesn't mean there can't be a complication. It just means there's less exposure to the potential for a complication. And so that always needs to be taken into consideration. And so the things that we inject are called orthobiologics. Just to set up a little foundation, we all know that we can heal, right? We've cut ourselves, we've known or have ourselves suffered broken bones. And guess what? We get new skin growth. We get new bone growth. We heal from surgery. It's not the surgery that heals you. Sometimes it's the surgery that helps stabilize things, but then your body has to actually regrow tissue that's been manipulated surgically. So there are cells involved and chemicals and growth factors and things involved with promoting a healing response. And we're just trying to take advantage of that process or create a more robust signal for healing if our natural mechanisms aren't doing what they're supposed to do, or there's tissue that just doesn't have good blood supply. So your cartilage, your meniscus, your disc in your spine, your labrum in your shoulder and your hip, parts of tendons, parts of bone has reduced blood supply. So these are all things that can be treated if your natural mechanisms aren't enough to try to keep them maintained. And so these are just cells we isolate from your own body. At least at this point in time, this is what we're allowed to do. So we can take cells from the blood. There's proteins in the blood that help rebalance inflammation and keep a homeostasis. We have cells within our bone marrow that can be isolated. These mesenchymal cells that help maintain our orthopedic tissues. These can be isolated in high concentrations and placed via injection-based procedures in areas of lower concentrations that need assistance with healing, and it can help promote your body's natural mechanisms. And so, for example, one of the cells that we use are called platelets. And these are found in your bloodstream. They have many functions, and one of their functions is to promote healing. And so they carry these different growth factors, and these growth factors are what help stimulate different components of a healing cascade. So some growth factors help stimulate cell growth, new blood vessel and collagen production. Some help improve vascular growth, tissue repair and cell growth, wound healing, growth of cells. And so we can take advantage of these properties by extracting these cells from the blood, concentrating these tissues so there's more in a given volume. And then you can use a needle to precisely place these into an arthritic joint, an inflamed tendon or small tear in a tendon, an inflamed bursa, a small meniscus tear, a disc irritation in the spine. These are all things that are treated with platelets. And the concentrated form of this is called PRP, platelet-rich plasma. There's proteins in your blood. There's one called A2M, which is a very, very strong anti-inflammatory protein, which can be used to help reduce swelling and cartilage breakdown. So people that have arthritic joints can build up these inflammatory arthritic chemicals, and those linger around in the joint, and they're kind of like demolition chemicals. They go and they kind of break down your cartilage, they weaken it, they destroy the matrix that holds the cells together. And these types of proteins can be used in joints that maybe aren't keeping up with the inflammation to help kind of protect that tissue. And so we can take advantage of these properties by just doing a blood draw, isolating these proteins, and via injection help improve some of that. And then within your bone marrow, which is where we isolate these mesenchymal cells, your bone marrow contains these mesenchymal stem cells. And these are cells that respond to injured environments. They help direct tissue repair. In the lab, they have properties where these mesenchymal cells can transform into different cell lines, such as cartilage, bone, muscle. And so we use these in typically more severe conditions, like a little bit more advanced changes in, say, arthritic change, bigger tears, or maybe tissues that aren't responding as well to, say, PRP or A2M or those kind of things. So we tend to use them for the more moderate to severe conditions. And again, these are isolated from the bone marrow. So it does take a little bit more to get these cells, since you have to actually aspirate them from the bone of the pelvis. The nice property of these is they're self-renewing, and they tend to start as perivascular cells, so cells around your blood vessels, but they can self-renew. So you extract them and these things can repopulate. So that's the nice kind of property of these cells, is you're not getting rid of them by using them in other locations. I always like to point out that there is data and research on different conditions. Some conditions have more studies than others. And so just a brief summary through last year for orthopedic stem cell type. Since 1997, lots of different studies are out there looking at different conditions, different outcomes, different types of injections and treatment, some combined with surgery, some not combined with surgery. And so there's data that's out there. This is specifically related to bone marrow data, PRP data for, say, knee problems. This is just PRP data in general, actually. So knee, comparing it to other injections. So say, for example, for the knee, PRP has been compared to gel injections. And in every study was more effective than gel, more effective than exercise, more effective than medications, multiple injections, cortisone injections. And then for different parts of the body, hip, hand, shoulder, carpal tunnel, some spine issues, and Achilles. So that's just using your own platelets to treat these things. There is data comparing it to other more traditional treatment options. PRP and stem cell data looking at for knee conditions as well. So when people, sometimes we'll hear some people say, oh, there's no data on it, there's no research. It's just because they haven't really looked. There's actually a lot. So obviously there's always room for more higher level, continuing to study what's the best indication for things, but we do have a lot to pull from. As I mentioned, as an organization, we're tracking about 40,000 patients right now in our treatment registry, on different parts of the body. So that also helps us understand what's working and what's not working within our own protocols. And so, speaking of that, there needs to be a process since these are medical procedures for medical conditions, there needs to be a process by which we try to predict, are you a good candidate? We have to have the right laboratory equipment to be able to isolate and get the cells that we want. And then we have to be able to deliver those cells to the problem area. Is your disc the problem at L5? Is your rotator cuff, your supraspinatus tendon the problem? Is your meniscus or your knee joint the problem? Or is there multiple issues within your knee joint or your ankle that need to be treated at one time? You got to get all of these products into the right location in order to give people the best chance for improvement. And so, as I mentioned, we only treat orthopedic problems from the neck, shoulder, elbow, and hand and wrist, hip, knee, and ankle conditions. These are all things that we see and treat. We don't treat like organ dysfunction or brain or those kind of things. We don't do those kind of things here. So in regards to prediction, there's kind of a few components to it. We have our evaluations. Again, I mentioned the registry, and there's always research that we publish or other people publish that we have to keep tabs on. And so our evaluations are pretty extensive in the sense that they're usually at least an hour long. We like to review medical history and imaging and do a physical exam. We do an in-depth review of your imaging. If you have an MRI or a CT scan or X-ray, we do some ultrasound in the clinic for extremities. And this is really where we get a sense of what's going on, what the problem is, how bad is it? Is it mild? Is it severe? Do we think we can help? What are all of the options, right? What are the options? Is maybe therapy the best way to go? Maybe you need surgery, or maybe the Regenexx treatments can be helpful. And so that's what we discuss during the evaluation, and we develop our customized treatment plan. As I mentioned, on regenexx.com, it has our kind of ongoing registry data, which can be broken down by different body parts. So it's always a useful resource for patients. There's also a list of published research articles that doctors within Regenexx have published. So those are always good to look over as well. So the whole process of looking at our registry data, checking the patient, what's the problem, how bad is it, what's going on, helps us determine if somebody's a high responder, a moderate, or a low responder. And this is all different based on your hip versus your knee. Hip characteristics are different than knee characteristics. Same thing for spine or shoulder. So we have to determine this by imaging and exam findings. So people will often ask, well, what are the success rates? Well, it depends. It depends on what we're treating and what's going on in that specific area. So it's really hard to just give a general sense because it depends on the problem. But without the process to evaluate those things, people will never truly know and have a good understanding of what the expectation is. And so once we make the decision that we think what we do would be a good option, then you have to have the right platform to be able to isolate these cells in the concentrations that you need, the dose that you need to treat the conditions that you find to be problematic. And so we have a flexible lab platform because dose matters. So you have to get the right concentrations. Just like in order to treat an infection, you need the right dose of antibiotics. In order to give yourself the best chance for improving from a PRP injection, you have to get the right dose. And so it's very important that you have a good flexible platform to be able to do that. So we do everything manual processing, and things can be customized based on age, location, tissue, severity. And we can get multiple types of products if we need. One area needs bone marrow, the next one needs PRP or some growth factors or a little A2M. We can get all of these things in one setting, where most other clinics have a one-size-fits-all approach. They have a little machine that spins, it pumps out a product, everybody gets the same thing. So just something to think about in regards to making a decision on on who to see for these types of things. So once we get all the cells that we need, the concentration, whether it's PRP or bone marrow cells or A2M, you got to be able to deliver these via image guidance injection procedures. So these aren't blind injections where the doctor just feels where the pain is and pokes. It's about understanding what the problem is so you can get right to that problem. And so we tend to get MRIs ahead of time so we can identify, like for, in this example, kneecap arthritis, where they're losing some cartilage, a little bone injury and swelling, and then the x-ray kind of showing where things are going. Not everybody needs this level of procedure as far as injecting the bone, but some people do. This is an x-ray showing the labral injection and joint injection of the shoulder. An ultrasound guided injection of the carpal tunnel. This is your median nerve. This is a needle injecting platelet growth factors around the nerve to help treat carpal tunnel syndrome. And so these 3 steps we feel make a big difference in regards to outcome. Not everybody's a candidate. So that's, if you go to a clinic that says, oh yeah, 99% of our people get better, without kind of qualifying what types of conditions those people had, that's a sign that they're probably not being completely honest. Everything has successes and failures. No one treatment option helps everybody. Even with the same level of problem, the success rates can vary between every individual. So nobody can specifically predict how well you're going to do, but we can look at thousands of people that we've treated and say, on average, this is how well people do. And it's because we've done, we've tracked patients and we do the research and we keep tabs on all those things. So it's just an important process. And so, for example, if we were going to do, say, a PRP injection where we're taking your blood and isolating your platelets, that's basically just a 1-day procedure. There's a blood draw, there's our processing time, and then there's the re-injection. Again, we use ultrasound or x-ray guidance to treat the different problems. For spine, for example, you will use x-ray. For a knee, we might only use ultrasound or a combination. I treated some ankle joints today, and we used a combination of x-ray and x-ray, x-ray and ultrasound, just because one gives me better vision of the soft tissue, the other gives me better vision of the joint spaces, so I can see where everything's going. So the other thing that people ask is, like, is there downtime? Do I have to restrict activities? And the answer is there's a period of about 2 to 3 days where people get a little flare and pain and inflammation because of the injections. That calms down. In general, we say about 2 weeks of modified activity. Most people get back to work within a couple days. Now, some people do need physical therapy. Some people need bracing. Some people need more restrictive activity after a procedure. For example, if you had a big tear of your meniscus or your rotator cuff, you need to protect that more than if you just had inflammation. So some people will need a brace or a sling. It depends on the problem. So, but in general, for people that have general things like arthritis, inflammation, maybe small tears in tissues, there's a little restriction, a little therapy, sometimes some bracing. And then we tend to track people every 6 weeks to see how we're doing. There's always some people that need more than one injection. It's not always a one and done. It does depend on the person, the problem, those kind of things. So it's hard to predict that, but there's always a percentage of people that need more than one treatment. In general, these are not cures for, say, arthritis. They can help manage the symptoms and the pain and strengthen tissues and things. But they're not going to cure people of, say, like bone on bone or something, So sometimes pain can come back in the future. If we do the bone marrow procedure where we're taking those mesenchymal cells from the bone marrow and treating, say, an arthritic shoulder, hip, knee. We have 3 steps to it. So step 1, step 2, and step 3. This all takes place within 7 days. So we kind of promote inflammation through something called prolotherapy injections. And then 2 days later, we take and isolate the bone marrow, and then we inject those cells the same day. Now, these things have to be done same day as the extraction. Again, we treat with ultrasound or X-ray guidance. And again, there's going to be a little pain and inflammation, a little recovery period. About 4 to 7 days later, we inject our post-injection, which is kind of feeding the area with platelets and growth factors, which can be beneficial with just progressing the signal for healing and trying to help keep the activity going in the area that's being treated. And so when you're using bone marrow derived cells, it's a little bit more involved when you're treating an arthritic joint. You might not do this whole process for, say, like a soft tissue problem, but mostly for joint conditions. And as I was mentioning, sometimes there's a little too much hype around that stem cells are the cure for everything under the sun. There are limitations. There is data for us to see where some of the failures are. We don't see a 100% bone-on-bone joint become a brand new joint, meaning 100% growth of cartilage. That doesn't happen. We haven't seen that yet. So same thing with discs in the back. We don't see, a completely collapsed disc become a brand new high, tall disc again. Tears beyond a certain size and tissue won't heal. So if the gap is too big, you're not going to be able to heal that with an injection. So some things do need surgery. So it's about being smart. If it sounds too good to be true, it probably is. The same thing goes with these types of treatments. There's successes and failures. There's good candidates and poorer candidates. And so we need to understand that. We don't use umbilical cord products because of FDA regulations here. They've sent out multiple letters that these are not compliant and that people using them can be subject to losing their medical license or a whole host of things. There's been big clinics that have been shut down, a lot of warning letters sent out. Not to mention all the umbilical cord products and amniotic tissue products are dead tissue. They're dead tissue. There's no viable cells in any of those products in the United States, which is different than, say, an isolated cultured product that can be done outside the US. It's just not allowed inside the United States. And so we did some studies looking at bone marrow cells, which are these purple colonies. These are all stem cells versus umbilical cord products that grew out zero. So we hear a little bit about umbilical cord tissue sometimes being the best thing, but what's available in the US doesn't have any cells that are alive. So it's kind of better to use your own tissue, which we know we can get viable cells from. There has been recalls in the past, and there's just less studies on the use of these things. All of the studies available with umbilical cord stem cells are done outside the US. And so because these are all cultured cells, meaning they're grown in the lab for a period of weeks to purify them and isolate them, which is not allowed in the US. And so there's just less data, although it's growing. And so maybe eventually we'll be using that more once we get clearance and a little more data on safety and efficacy. So right now, everything we do is what's called autologous treatments, meaning we isolate these from your own body. And so until we get a little bit more compliance, a little bit more confirmatory studies, some standardization for using a donated source of tissue going into somebody else that isn't related, there can be a risk for rejection and those kind of things. And so we're still sticking to using your own tissue, which we have a lot of safety data on. And so, okay, a lot of talking. We went through that pretty quickly. I really want to spend some time getting to questions. So if people have any, they can write them in the chat or the Q&A section. I try to highlight some things as we went through about, different questions that people ask. Sometimes people ask about treating multiple joints at the same time. It's definitely possible with PRP to treat multiple areas, 2 knees and a shoulder, a spine and a knee and an ankle. It's a little bit harder with the bone marrow procedure. Again, as I said, dose matters. And since we're not allowed to grow out your cells in the lab, we're at the mercy of what we can isolate within the laboratory process. And so not everybody, we can't harvest enough to treat, say, multiple joints at the same time. At most, you can treat 2 areas at the same time with the bone marrow process, depending on the size of the joint that we're treating. So the question, does it work for ACL tear? Is there any data or patients that had a success? So yes, so we've published quite a few studies on ACL tears. Let me see if I can just pull it up on here. So we did do a case series on ACL tears, and let me see. So yeah, depending on the type of tear, that's something that needs to be looked at in detail. So we do have kind of a software that we use to be able to measure specific things on MRI as far as what the ACL looks like, what kind of offset somebody has with where their femur and tibia kind of line up on the backside of the knee. And so depending on the type of tear, usually partial tears or complete non-retracted tears, we have had success with. We just published some early findings here. This is on regenexx.com. You can find it under the research tab. Image guided injection of the anterior cruciate ligament with bone marrow and platelets. This is just a midterm analysis. It's a randomized controlled trial comparing it to physical therapy. So here in conclusion, this is still early findings. Bone marrow concentrate injections to the ACL tears improve patient function compared to exercise observed through 24 months. So that's a more recent study that you can go through. I don't want to walk through it, for everybody, but it's something you can look at. There's also other studies here. We did do a case series. Let me see if I can point it out right here, 2015, where we had kind of a small number of patients in this one, but we have probably 100 plus pre and post MRIs with ACL tears showing healing after injection. And so these were grade 1, 2, and some grade 3 tears without retraction that was treated with bone marrow. And we also have some before and after MRIs for ACL. So this is a blown out, complete non-retracted ACL tear. And this is showing a normal ACL after treatment. And this is about 7 months after treatment, if we look at the dates of the MRI. More ACL injuries that have been treated here and here, here and here, complete tear here. So yes, but there are some things we look at on imaging to determine your overall candidacy for the procedure. And so an MRI is definitely needed, and it needs to be updated for us to be able to give people a sense of the overall chance for success. Other questions? Well, I'll just go to the next slide. I need to update this because Lauren is who's doing most of our patient scheduling now. But we can use this data still, the phone number and the email. If people have more questions or want to send in their lab, or not their lab, you can send in your laboratory work too, but their MRIs or imaging to see if they were potentially a candidate. We don't like to make decisions just on the imaging, but it gives us a good sense of if there's something so completely on the scale where we're not going to be able to help. Sometimes it's good to know that ahead of time before taking time out of your day to come to the clinic, although I think people do derive benefit from even coming into the clinic because we try to spend some time talking to people, but people can send in their information. So this is who you can contact to send in information or get more information or get in touch with us here at our clinic here in Henderson. So that's something to jot down as well. And usually they'll be in contact with you anyways, just to see if you have more questions. So I don't really see any more questions. I appreciate everybody taking their, an hour out of their evening to listen to me rant for a while. Hopefully there was some useful information. Again, this is more kind of a general overview. We will have more in the future on joint specific options and stuff. So if you have more questions, reach out to us. And if not, take care and have a good night.